Hello everyone, good afternoon, Hare Krishna. How are you all? Today we will discuss from where we started. Yesterday we missed the class, but let's discuss about the we was on the question number 38. See, a neonate is 5 days old. What vaccination dose of BCG vaccine in milligram is necessary for vaccination of this child? See, yesterday we discussed that the BCG strain. In yesterday class, we discussed about the BCG strain. So, whenever you see there is a BCG strain, so always remember there is a Dennis 1331, and the full form of the BCG strain is the Bacillus calmette urine. How we will take it? We will take it intradermal. How we will take it? We will take it intradermally. See, then after we will have, remember the dose of vaccination in mg is 0.05 mg. That is the dose of necessary for vaccination of this child. Then remember we have the 39, question number 39. Yesterday we discussed about that there is a chronic sinusitis, recurrent pulmonary infections, so and right-sided cardiac sellout. So this condition is known as the dextrocardia. So this condition is known as the situs inversus. This condition is known as the situs inversus. So this we already discussed, like the Carter-Jenner syndromes or the immotility cilia syndromes that we discussed yesterday. Then we discussed about these questions. RH incompatibility was there. So what is the most appropriate treatment for the of hyperbilirubinemia in this patient? That is the exchange of the blood transfusion. Then we studied. Then this question. This is the atelectasis. See, this question, yesterday we studied about the lungs pathology, about the bronchitis, bronchial pneumonia, lobar consolidations. So atelectasis, see, remember we have the atelectasis. So remember the atelectasis means that is the consolidation of the lungs, the consolidation. So if any consolidation, that means atelectasis is there. Now here you can see a 4-year-old girl was playing with her toys and suddenly she got an attack of cough or dyspnea. See, if any history of children is there, like the 4 year, 5 years, so what they will take? They take everything in their mouth. So playing with her toys. So what she did? She took it act as a foreign body and she engulfed the foreign body in her mouth. And attack of cough or dyspnea, this is due to aspiration. The aspiration of what? The foreign body. Due to aspiration of the, this is due to aspiration of any foreign body. Due to aspiration of any foreign body. So that thing cause the cough and dyspnea in this baby. Objectively, we can see the respiratory rate is 45 minutes, heart rate is 130 per minute. Percussion revealed there is a dullness of percutatory sound on the right in the lower parts. See, if any dullness is there, if any dullness is present in any part of the lungs, so if dullness is present means something heavy thing is there, or we can say the water is there, we can say any liquid particle is there, or any there is a mass, something mass is there present in that regions. So auscultation reveals the diminished breath sound with the bronchial resonance on the right. X-ray picture showed the shadowing of the lower part of the lungs. So if there is a shadowing of the lower part of the lungs on the right, okay, when we are taking the X-ray, we are seeing that is the shadowing of the lower part. It means there is something more dullness, or whenever you see the dullness and any shadowing means that is the whitest. Shadowing means that is the whitest part will be there. So that things we always remember, that will be looks like the patient is having something, the water, liquid, or any solid mass is there, then it looks that it gives the dullness voice when we are doing the percussion. Blood analysis reveals there is no sign of inflammation. The child was diagnosed with a foreign body. That we only diagnosis if there is giving any history of any children with any foreign body and suddenly there is just attack of the cough or dyspnea, that in that conditions always remember due to aspiration of any foreign body, this baby will be having cough, dyspnea or these symptoms. And this is the most common site for the foreign body disclosed, that is the right bronchus. That is the right bronchus. Remember this is for one word, that is due to like some gravity effect, it will go to the right bronchus sides, and there is easy to go on the right bronchus. That what complication cause such clinical presentations? So this condition, remember this condition always remember, this is what, that is atelectasis. This is what? Atelectasis. So this condition is atelectasis. The atelectasis, what is there? whenever you see the consolidation or any collapse of the lungs, consolidation or the collapse of lungs, there is a collapse of the lungs or any lobe, that is what atelectasis is, and that is the complication of the foreign body aspirations. It affect on the lungs, and like the peoples who having any inhaled objects, it can be the complication of asthma, it can be complication of any foreign body inhalation or other lung injury, and or maybe there is a direct injury to the lungs that can cause the collapse of the lungs or any lobe of the lungs. That means that is talking about the atelectasis. The emphysema, we know that it doesn't happen. In emphysema they will give you something expansion of the alveoli. Bronchitis, we know there is a inflammation. Here we are seeing there is a no sign of inflammations. Here you can see there is a no sign of inflammations. Then we have the pneumonia and the pneumothorax. So what pneumonia or the pneumothorax, when they're talking about the pneumonia, so always remember the pneumonia we will discuss in the previous classes. So there was something history of the fever will be there, but there is a no history, and along with that there is something the patients can be having the some homogeneous mass, or there's something mass will be given in the questions. Pneumothorax, we know that is due to air. So they, in pneumothorax, what we will see, the air will be there and there is a hyperresonance will be there. Hyperresonance means the black will be air will be looks like the black on X-ray. Air will be looks like the black on X-ray. That you need to remember. Then the question number 43. I hope this is understood. See, if any foreign body is there and due to which there can be the aspiration pneumonia, if any foreign body objects will be there, that complications can lead to the atelectasis. There can cause the collapse of the lungs or collapse of any lobe of the body. Mainly here will be the right bronchus is there, so the right lobe will be affected. Then question number 43. See, in question number 43, a man 42 years old, a road accident after the hemorrhage of the sport because of acute hemorrhagic anemia. So what minimum percentage of whole blood volume could result in the death by acute hemorrhage? So always remember whenever you see this type of the question, so in this type of the questions, always remember here in the question they are given a man 42 years old that died in the road accident. So any road accident, of course there will be the blood loss. There will be the blood loss will be there. After the hemorrhage on the spot because of acute hemorrhagic anemia, of course the hemorrhage means there is a bleeding loss of if any road accident can be there possible, there can be the blood loss will be there. Now in the questions, if how much blood loss will be there, what minimum percentage of the whole blood will be there, so that remember that will be the 25 to 30%. That will be 25 to 30%. See, if we categorize these conditions, like if having blood loss, if we having the blood loss that is 1, that is less than 15%, or it can be 15 to 30%. We categorize this into the classes, blood loss like class 1, class 2. In the class 2 the blood loss is 15 to 30%. Class 3 there is a blood loss is 30 to 40%, and the class 4 the blood loss will be around more than 40%. So in both these conditions, this is just normal conditions, so we can the patients can respond to the normal therapy. The patients can respond to normal therapy. The patients can respond to the normal therapy. But in case of like 30 to 40% or more than 40%, we need to do the blood transfusions, because there is a patient is going into the anemia. If there is a major blood loss, the patients can go into the hypovolemic shock as well. If major loss or major blood loss is there, the person can go into the hypovolemic shock. Hypovolemic shocks, the fluid loss from the body, that the patients will be having the decrease in the blood pressures, and along with that heart rate will be increased, and the patient having the major blood loss. So remember the blood transfusion we need to do, and the patients can having the death on spot because of the, if more than 30%, then the patients can having the death on the spots, and we got very like 1 to 3 minutes you can say 1 to 3 minutes the people will get. Okay, Just a second. On YouTube. So there is a death on the spot, so and the minutes will be there. Then after that, so remember, if you have the 25 to 30% blood loss, so that is the minimum person could result in the death. That is the minimum percentage. If the 25 to 30% blood loss is there, then these patients can respond to the normal therapy. The the answer should be for this question should be 35 to 40%. But according to the because different country having they have the different guidelines is there. So according to that, remember that if you have the 25 to 30% is given in the questions, that can also the minimum, because they asked the minimum. The minimum is the 25 to 30%. In 10 to 14% and 15 to 20%, we can respond to the normal therapy. But if there is a 25 to 30%, because this is like prone to the death. So whenever we are going to this sides, the class first to the class fourth, then the severity or the prone to the death will be increased. The prone to the death will be increased in that case. Less than 15%, 15 to 30%, 30 to 40%, and more than 40%, that responds to the normal therapy. But if there is a 25 to 30% is there, then always remember the 25 to 30% is there, then remember that this is the minimum percentage that could result in the death by the acute hemorrhage. And if the people are having in the death on the sports, that is possible with the 35 to 50% loss. I hope this is clear. Okay, I'm repeating it again. See, if any blood loss having the 25 to 30% blood loss is there, 25 to 30% blood loss is there, then remember ki this is the minimum percentage that can cause the death by acute hemorrhage. But if there is a 35 to 50%, there is a death on sports in minutes can possible. But this is what, this is the minimum percentage that you need to remember. See, if read the question carefully, if they are getting the questions minimum percentage, so minimum percentage will be 25 to 30%. But here I'm saying 30 to 40%, more than 40% death on the sports per minute. That is the like the people having the death in minutes. But here if you are seeing there is a 15 out of 15, then when you are going to more blood loss, more prone to the death. Okay, I hope this is clear and you understand it easily. A 6 week, then we having the a 6 weeks old child is admitted because of the a 6 weeks old child is because of the tachypnea. See, birth had been uneventful, although the conjunctivitis developed. See, there is a conjunctivitis is there on the third day of the life and lasted for about 2 weeks. See, third day of the life and lasted for about 2 weeks. Physical examination reveals the tachypnea. There is a bilateral inspiratory crackles and single expiratory wheezing. Bilateral pneumonia is evident on the chest x-ray. The child is afebrile, means no fever is there or fever is absent, and there is no history of fever. White blood cell count is given with 28% of eosinophil. The most likely cause of this child's symptoms is. So this is the case of the chlamydia trachomatis. Why the chlamydia trachomatis? We know that conjunctivitis, there is can be the the three things. It can be the gonococcal conjunctivitis, it can be the chlamydial conjunctivitis, or it can be due to gonorrhea, it can be due to chlamydia, or it can be the possibles due to any other conditions like the due to any chemicals. Okay, so let's discuss about the chlamydia and all. Okay, I'm writing it here only. See, if you're having the if you're having the conjunctivitis, see the conjunctivitis, when we talk about the conjunctivitis, see conjunctivitis, we have the three type of the conjunctivitis can be possible. Whether it can be the chemical conjunctivitis due to any chemicals, whether it will be gonococcal, it could be gonococcal, or it could be the possibles because of we have the chlamydia, because of chlamydia. Okay, the chemical, remember the chemical, if we talk about the chemicals will be like this due to like there is a mild conjunctival swellings we will see in case of chemical conjunctivitis, mild conjunctival swellings, and it is within the 72 hours of the life, within 72 hours of life. And what these conditions will be the self-limiting condition. This will be the self-limiting conditions. We no need of any treatment is usual, and if the self-limiting, we can use the reassurance. If any patients comes to us, then what we will do? We will reassure the patient. What if it is gonococcal conjunctivitis? See, gonococcal conjunctivitis, or what if it is chlamydia? So gonococcal conjunctivitis, mainly it appears in within the 2 to 5 days, or maximum till 1 week. Then in gonococcal conjunctivitis, what we see there is a purulent discharge. There will be the purulent discharge will be seen. And what the treatment we will give in this condition? That is the ceftriaxone. This we already studied when we talk about the gonococcus, the treatment, that is ceftriaxone. In chlamydia, the conjunctivitis is possible within the 7 to 14 days and minimum like 2 weeks. Then in chlamydia, here we are seeing purulent discharge, but here what we will see the mucus along with the pus, and that will become the mucopurulent discharge. But it will become mucopurulent discharge, and this can lead to the atypical pneumonia. Don't worry about the typical, atypical. Just remember there is a atypical pneumonia. You can remember just that there is a typical pneumonia is there. And the treatment for in these conditions, what the treatment we will give? We will give the oral erythromycins. What the treatment we will give? Oral erythromycins will be given. Okay, I hope this is clear. So this is what chlamydia trachomatis. So here we can see there is a conjunctivitis that develop on the 3rd day of life and lasted for the 2 weeks. Then here we can see the conjunctivitis and maximum till 2 weeks. So the tachypnea, bilateral inspiratory crackles, single expiratory wagings. There is a pneumonia is there. That is what evident atypical pneumonia that we seen in case of the people having the chlamydia or the conjunctivitis. Now let's continue with little more about the chlamydia. See, when we talk about the chlamydia, so there is two things like chlamydia trachomatis. So that is the most common infections, like they cause the conjunctivitis. And in your previous like Croc 1 classes, maybe you studied about the chlamydia is what? That is the gram negative. It is the gram negative cocobacilli. It is the gram negative cocobacilli. It is the non-motile. It is non-sporing. Non-motile, non-sporing. Non-spore formation means no spore will be there. And it is the obligate intracellular bacteria. It is obligate intracellular. What is the meaning of obligate intracellular? I hope everyone knows it. The obligate means exclusively present inside the cells. They can grow inside the cell only. Then remember that when we are talking about the chlamydia trachomatis, they have the inclusion bodies. So remember, in case of chlamydia trachomatis, we have the inclusions bodies. So what it contains? It contains the glycogens. And for that, what the stain we use? That is the iodine stain we use. But just remember, they contain the glycogenic inclusion bodies. Then remember, when we talk about the chlamydia, see, they can cause the genital infections as well. When we talked about the gonorrhea and all these things, I talked that there is a chlamydia infections, and these are like brother sister. They have the like very good relations. When the gonorrhea is there, there can be the possibility of the chlamydia infections as well. That can the super infections we can say. So when we talk about the genital, here I am writing the genital chlamydiasis. See, in case of genital chlamydiasis, it is the most common bacterial, sexually transmitted disease. See, if we are getting the most common bacterial sexually transmitted disease, so remember, when we treat the patients or any female patients having the chlamydia, so in that patients we also treat the male partner also. Why we treat the both? Because it is the sexually transmitted disease and it can transmit to the male as well. That's why we treat the both the partners. Then it is the most common cause of urethritis. If any inflammation of the urethra is there, so it is the most common cause of urethritis, or maybe that we call it non-gonococcal urethritis. Non-gonococcal urethritis. Okay. Also remember where we studied about the reactive arthritis. The reactive arthritis, I told you, that is the most common cause of reactive arthritis. The most common cause of the reactive arthritis, what was that? That is the chlamydia. I hope you remember. If you don't remember, just revise the previous notes. See, there also we discuss in the reactive arthritis when we was talking about the chlamydia. See, here it also cause the urethritis that we studied, and also we studied that is the most common, it causes the urethritis, and after that it can also cause the proctitis, the inflammation of the prostate gland, and we already studied that it causes the reactive arthritis as well. Okay, in the female it causes the cervicitis, endometritis, or we studied that it also causes the Fitch, Hugh, cuties. Who is the cuties? Female are the cuties. So remember, CURTIS, cuties syndromes. Okay, the cuties syndrome. So remember Fitch, Hugh, cuties syndrome, and that is what that is seen in case of the female having the chlamydial infections. I hope this is clear. Okay, now let's come back to our questions. See, we have studied about the chlamydia trachomatis. We studied that there is a conjunctivitis, and that is least minimum maximum like 7 to 14 days minimum. That is the scenes. Here I am giving the third day of life. So third day of life is started, but the normal range is what? That is minimum like 7 to 14 days in the most of the books you can say. But third day of life, that is also the correct, because we need to check if it is like maximum till which weeks, or maximum till which day. So that you need to understand. There is, along with that, we can see there is a pneumonia also. So that condition we can call that is the chlamydia trachomatis. Varicella zoster virus, that is we studied in the previous class, that is the chicken pox. Mycoplasma pneumonia, what they cause? They cause the walking pneumonia. Pneumocystitis carini. So remember, this is the opportunistic infections. That is seen in case of opportunistic infections, seen in case of HIV. So remember, pneumocystitis carini, that is the opportunistic infection that is seen in case of HIV patients. Opportunistic infections means that in case of, when we talk about the HIV patients, see, in case of HIV patients we will be having some in HIV patient we will having the immunosuppressive patients. The immune system will be suppress in case of HIV patients. So whenever the immunosuppression patient, there can be the loads of infections or the super infections or the opportunistic infections can be possible in the HIV patient because of immunocompressions. And so what is the pneumocystitis carini? This is the example of the opportunistic infection that is seen in case of HIV. Okay, I hope this is clear and done. I hope no one have any problem till now. Okay, so I think no one have any problem. Okay, so let's continue with that further. See the next questions. I think I was teaching you here the HIV. Okay, but let's do that in the next class. HIV will be the like big topic, so we will do in the next class. See, next question. A 6-year-old asthmatic patient was taken to the emergency hospital because of the severe coughing. So there is a asthmatic child. We know in asthma there is a bronchoconstrictions. Every time we are seeing there, we saw that there is a severe coughing is there. We stated that there is a wheezing, rails will be there. Reveal the child is excitable, has intercostal and suprasternal retractions. So this is the like the feature of any airway obstructions. We can say the intercostal or suprasternal retractions. There is expiratory wheezing throughout all lungs filled. Initial treatment may include the prescription of. See, if any asthma patient is given, if any asthma patients came to you, so we can give this asthma patients. So there can be the possibles. We know that we need to do beta 2 stimulators, because beta 2 what they cause the bronchoconstrictions. So if we will stimulate the beta 2, what they will do, we will have the bronchodilations. So in case of beta 2 we will do the salbutamol, beta 2 agonist. So other than that, if the questions in the question you are getting the steroids or option is in you getting the steroids, then mark it. Along with that you are getting the epinephrine here. See, epinephrine or norepinephrine. I hope you all remember that in case of epinephrine, so epinephrine they stimulate all the receptors. Epinephrine, what they do, they stimulate all the receptors. They stimulate the alpha 1, alpha 2, beta 1 and beta 2. They stimulate all the receptors. Here we have just that is beta 2. We need to stimulate just beta 2 for the bronchodilation. But here in case of epinephrine, of course the epinephrine is not good drugs in case of just asthmatic patients. But here the other options are not possible. See, the parenteral phenobarbital, parenteral is IV. Phenobarbital we give in the patients having the anxiety, and this is the antidote of barbiturates. Antidote of barbiturates. So of course this is not the possible drug for asthmatics. N-acetylcysteine and the cromolyn by inhalations. I hope you remember. I think it was the second or the third questions from pediatrics base. So in the cromolyn we studied that it is stimulate the mast cell, it inhibit the mast cell. So that's why there was a questions which drug is not possible or not a appropriate treatment for these conditions. So here there was answer was the cromolyn. So of course that is answer no possible. Gentamicin, remember this is the antibiotic drugs, the aminoglycosides. So that why it again not possible. We use in the condition of the pediatrics pneumonia. Then intravenous fluid in the first 2 hours. So patient having the obstruction is there. Would you like to give the patients having the intravenous fluids to compensate the water deficiency, or first you will treat the initial treatment with the like you need to bronchodilate the patients? So of course I hope everyone you do the bronchodilations. And so in that patient, that's why we are having the subcutaneous epinephrine. If in the questions you getting the steroids, then mark that. If you getting the salbutamol, of course that will be the answer. The salbutamol, that is the good drugs for the case of the asthmatic patients. So here is given subcutaneous epinephrine. Okay, if you are talking about the epinephrine, can you tell me about the norepinephrine as well? See, in case of norepinephrine, see in norepinephrine they have the effects on alpha 1, the effect on the alpha 2 and very less effect on the beta 1s. Okay, like very less. So main effect on the alpha 1 or alpha 2, they don't used for they don't stimulate the beta 2. They have just norepinephrine have the role in just alpha 1 and they stimulate the alpha 1 and alpha 2. I hope every one of you know what is alpha 1, alpha 2, beta 1, beta 2. These are the sympathetic receptors. Everyone you know that you have the sympathetic systems, and parasympathetic system. In sympathetic systems we have the alpha receptors, we have the alpha 2 receptors, we have the beta 1 receptors, and we having the beta 2 receptors. or we have the beta 3 receptors. All these findings we will discuss. Then we have the norepinephrine. Norepinephrine, remember, we have the alpha 1 and alpha 2. Then epinephrine, remember, this as it stimulates the alpha 1, alpha 2, beta 1, beta 2. This is the drug of the choice for anaphylactic shock. It is the drug of choice for anaphylactic shock. What is anaphylactic shock? What is the anaphylactic shock? In anaphylactic shocks, we will be having decrease in the blood pressures, sweating will be there. Along with that, they have the effect on the there is increase in the heart rate as well. So that is the anaphylactic shock. So it have the functions with the alpha 1 as well, alpha 2 as well, beta 1 as well, and beta 2 as well. So all the tremors will be there. So all this seen that is seen in case of anaphylactic shocks. So that's why we give the drug of the choice for this condition is the epinephrine hydrochloride drugs. That's the drug of the choice for anaphylactic shock. Okay. Then the next question. I hope this is clear. Then the next question, we having a full-term infant was born after a normal pregnancy delivery, however is complicated by the marginal placement detachment. At 12 hours of age, the child, although appearing with good health, passes a bloody meconium stool. Okay. For determining the cause of the bleeding, which of the following diagnostic procedures should be performed first? So what we will perform from the behind. So barium enema. See, whenever we talk about the barium, sometimes we called it barium enema, barium meal, or barium meal follow through. So on all these conditions, what is this actually? See, barium contrast you can write. Barium contrast. See, in case of the barium contrast, when we studied, we use the barium meal. So what the barium meal do? The barium meal, when we are taking the barium and we put the contrast or it as a dye, you use barium as a dye. We put the contrast and we put the dye in our esophagus or in the mouth. So that is called the barium meal. So any esophagus problem is there. So which techniques we use? That we put the barium meals. In case of stomach as well, we use the barium meal. In case of stomach as well, what we use the barium meal. Then in case of barium meal follow through, the barium meal follow through, we give the barium meal and after that we will follow the pathway, and this is done in case of the duodenum. This is done in case of duodenum, in case of jejunum, and in case of ileums. So if any problem in these three points, duodenum, jejunum, ileum, or this part of the small intestines, so that in that conditions we will having the barium meal follow through. Barium enema we will put through the anus and we will put a dye into that and put the lye so that we can find any abnormality in the large intestines. For example, in case of intussusceptions. So intussusceptions we do the barium enema, and in the barium enema we put from the behind or from the anus, and we will check the abnormalities, if any abnormalities in the large intestine, any obstruction in the large intestines. Like for example, the barium meals we use, that is for the esophagus. In case of the esophagus, we check about the eclasia cardia, we check about any carcinoma of the esophagus. Then again in the stomach condition, there is some other disorders that we studies like Bohr-Haave syndromes. In all those conditions, we use the barium meal conditions. So this you need to just remember. Okay, barium meal follow through, barium meal stomach, and barium enema, that is for the large intestine. Okay, so here you can see there is a normal pregnancy, marginal placental, 12 hours age, the child although appearing to be good health passes a blood meconium stool. So if he is passing the blood meconium stools, for determining the cause of the bleeding, so for determining the cause of the bleeding, what we will put, we will do the barium enema. So we will put a the contrast from the anus, and that's why we will able to determine the cause of the bleeding from which part of the, because if you're getting the blood in the stools, so that is the possibility that it is might having the problem with the large intestines. That's why we put the barium enema. Okay, if any problem in the stomach or the esophagus, there is more chances of hemoptysis uh, rather than the stool in the in case of the stool, the blood rather than blood in the stools. So in case of the patient having the esophagus injury, stomach injury, we can get the hemoptysis conditions, the blood in vomiting, so that type. Okay, other options are ruled out already. Platelet count, prothrombin, partial thrombin. This is not just the findings that we can able to find the with the can we find if any platelet count is increasing, decreasing. We don't know what are the cause of the bleeding still. Along with the prothrombin, thromboplastin, prothrombin we do in the extrinsic intrinsic pathway, partial thromboplastin times, and all these things we will do in the intrinsic extrinsic pathway. APT test, what is the APT test? So remember the APT test we used in case of the patients having the fetal or the maternal hemoglobin. So it is used to differentiate fetal, or we can say neonatal blood from mothers, or we can say maternal blood. Okay, so that you need to understand. Okay, so the next question we have, in the 43rd week of the gestations, a long thin infant was delivered. He is apneic, limp, pale, and covered with the pea soup amniotic fluid. The first step in the resuscitation of his infant at delivery should be. So let's continue with that on the other page, because that's the big topic. So this condition is what we call the, see, if any pea soup amniotic fluid is there, covered with a pea soup amniotic fluid, or the like some greenish color fluid, so that is what, that is the meconium aspiration syndrome. That is the meconium aspiration syndrome. And what is the meconium? Meconium is the first stools. Meconium is what? That is the first stool that we seen in case of the baby. Okay, let me just take this and we will discuss that. Okay, so let's discuss the big topic for today, that is the meconium aspiration syndromes. Meconium aspiration syndrome. See, in case of meconium aspiration syndromes, first you should know what is meconium. So meconium, remember, that is the first, meconium is what? That is the first stool of baby. The first stool of baby, we call this as the meconium. But we call this as the meconiums. And remember that meconium aspiration syndrome, this is the common in the post-term baby. Common in the post-term baby. Why? When we call it post-term baby, the post-term baby, when it will be more than 42 weeks. More than 42 weeks baby, we call this as the post-term baby. Okay. So this meconium aspiration syndromes we see in the patient having the post-term baby. See, in case of post-term baby, when we discuss, we will be having the polyhydramnios. What is the polyhydramnios? See, the polyhydramnios means there is a more amniotic fluid will be there in the, because as the baby is growing, there will be the more urinations, and due to more urination there will be the polyhydramnios. Other things also related to that polyhydramnios in case of post-term baby, that we will discuss in obstetrics and gynecology part. For now, just remember, in the post-term baby we are having the polyhydramnios, means very high amniotic fluid, and due to high amniotic fluid, of course the meconium will be the high amniotic fluids, the meconium or the stool formations will be more, and these stool formations will be surrounding the baby, and sometimes the baby aspirate that stool, swallow that stools, and that finally will lead to the meconium aspiration syndromes that we will study. Okay, So remember, this is the common in the postterm baby, and along with that it is can also seen in babies having the with IUGR, the babies with IUGR. The IUGR we will study, that is the it can cause the polyhydramnios, and it as well as it can cause the oligohydramnios as well. So the babies with the IUGR and the common in the postterm baby. So what happen in this case of the in this case, there will be the patients will having the increase in motilin. There is some element or the some chemical, you can say, that is increases, that is the motilin, and this motilin, what they do, they increase the GIT peristaltic moment. They increase the GIT peristalsis. If there is an increase in the GIT peristalsis, so what will be there? There will be the expulsion of meconium. There will be the expulsion of meconium in, see, whenever the peristalsis will be there, so there is an expulsion of the meconium inside the uterus, and where it will be expelled or the excreted into the amniotic fluids. Now this expulsion of the meconium is that the first stools, this is swallowed and aspirated. This is the swallowed and aspirated by the baby, swallowed and aspirated, or by the baby, the fetus, that is aspirated, and that will lead to the meconium aspiration syndromes. Okay, I hope this is clear till now. See, what will be the clinical features we will see. The clinical features that we see in these conditions, so there will be the partial block of, the partial block of main airways, Okay, so due to which what will be happen, the airway get trapped. Due to which what will be there, airway will get trapped. The airway get trapped inside the lungs. What the clinical features, or we can say, or the consequences, what the consequences or the clinical features we will see. See, there is a partial block of the main airways, and the airway get trapped inside the lungs, and due to which when the yesterday we discussed about when the obstructions in the previous classes, we discussed that when the obstruction is there, the airway, the expirations it will be the problem in the expirations. So we studied all the obstructive disease as well. In obstructive disease we studied that there is a problem in the expirations. So this airway gets trapped inside the lungs. The airway get trapped inside the lungs, and what will be happen during the expulsions? There will be the during expulsion, there will be the obstructive during exhalation, not expulsion, during the exhalation. So when we are expiring, there will be the over distension of the lungs. And that will lead to the obstructive emphysema. In emphysema we studied that there is a baggy lungs will be there. So remember that obstructive emphysema will be seen. So what will the seen in the case of the chest X-ray? So remember, in case of the chest X-ray we see there is a hyperinflation. What we will see? There will be the hyperinflation. So that is seen in case of chest X-ray. So we have the partial blockage of the main airway. When the meconium is aspirated, so that can lead to the aspiration or the aspiration that is done through the nose, the trachea. So when it is going to into the trachea region or into the airway regions, so this stool, they can cause the blockage or the partial blockage of the main airway, and this airway will get trapped inside the lungs, and when the baby is exhaling, so there will be the over distension of the lungs will be there, that cause the obstructive emphysema. And on the chest X-ray, what we see? In the chest X-ray we see there is a hyperinflations will be there. Okay, I hope this is clear. Now after that, if we having the complete block of small airway, See, if I told you that if any blockage is there, there is a possibility of the collapsing of the lungs or collapsing of the bronchi or the collapsing of the any lobe of the lungs. So if any complete block of the small airway, there will be the segmental atelectasis will be there. These patients will having, or the baby will be having segmental atelectasis. So this might be possible in the baby. Okay. See, if any obstruction is there, there will be the baby will be having the respiratory distress. So you need to remember what the respiratory distress, what are the features of the respiratory distress. There will be the features of the respiratory distress will be there. So what happen in the respiratory distress? Remember, if there will be the respiratory rate more than 60 per minute, if respiratory rate is more than 60 per minute, so that is what the respiratory distress. And also along with that, we will be having, the baby will be having the chest retraction. This baby will be having the chest retraction or indrawing. Chest retractions you can normally feel when you have any obstructions in your body, or whenever you are swallow also. So there at that time also there will be the chest retractions you can see in your body. Okay. So this type of the like the respiratory rate will be, if see, if suddenly you got the choking, you got any choking, so what will be there, you will choke. So that time respiratory rate will increase, and you trying to having the that obstruction should be clear out as soon as possible. So at that times you will be having the chest retractions. And also you can see on the pneumonia also we studied that there is a chest retraction or indrawing is present. Along with that there is a sound in the baby, the what is the grunting sound, the grunting, and there will be the cyanosis as well. Grunting and the cyanosis will be there. So remember, we will be having the grunting. What is the grunting means? See, if we are getting the expirations, we having the expiration in partially closed glottis. The expiration in partially closed glottis, that is what means of the grunting. So grunting means any sound or the like any sound or whistling type of the sounds, you can say grunting, that is the produced during the expirations in case of the partially closed glottis or any obstruction is there. So there can be the grunting sounds will be produced. And the cyanosis, because there is accumulation of the more carbon dioxide in the in our lungs. See, here we are seeing the over distension of the lungs, the airway will get trapped. So if the airway will get trapped, that will lead to the cyanosis in this baby. I hope this is clear. So what the causes that we can see in this baby, there is mainly the pulmonary cause. There will be the pulmonary cause will be there, that is the more common. Pulmonary cause, that is the more common cause that we see in case of meconium aspiration syndrome baby, and due to which this we call this as the aspiration pneumonia. We call this the aspiration pneumonia. What is the aspiration pneumonia? See, aspiration pneumonia, if we are aspirating any oropharyngeal secretion or the gastric content into our trachea, अगर एयरवे के अंदर हमारे किसी भी एयरवे के अंदर और जो पाथवे है, जो हमारा ट्रैकिया है और नासोफेरिंजियल एरिया है, उस पार्ट के अंदर if we are getting any oropharyngeal secretion or gastric content, we call this condition as the aspiration pneumonia. I'm repeating it again in English. See, if you are getting any aspiration of any oropharyngeal secretion or the gastric content, we call this condition as the aspiration pneumonia. So if there is a aspiration of oropharyngeal, the aspiration of oropharyngeal secretion or gastric content, so we call this condition as the aspiration pneumonia. I hope this is clear. What is the clue in the history you will getting? See, in case of the baby you will not get this type of the history, but you will getting the clue in case of the adult history of adults. We can say mainly the adults or the baby who is present out like in our environment. And this baby is in the The baby that we was talking about, the meconium aspiration syndrome, that is the post-term baby, the present inside the uterus. But here we are talking about if you are getting the want to get any idea of any aspiration pneumonia, like there is a clue in the history of this sputum, you will get the foul smelling sputum. You are getting the foul smelling sputum. See, one more conditions where you see the foul smelling sputums. So that is the again the in case of the Janker's diverticulums, there is a problem with the dysphagia. Janker's diverticulum that we seen. See, in the Janker diverticulum, there is a some pharyngeal pouching will be there, and when we are whatever we will eat that food, that will be stored in that pharyngeal pouch, and after some time that food will becomes the like that food will give the some smell, the strong smell, and that again will be the foul smellings. We will see foul smelling conditions. So this is just a like for you can remember from here about the Janker's diverticulum. But if in case of the aspiration syndrome, you are getting the foul smelling sputum, that is the main things. And the treatment for like any pneumonia, we studied that the empirical treatment, what we will do, amoxicillin, clavulanic acids, we can give the clindamycin or the, so all these things we can give in case of aspiration syndromes. Okay, so I hope this is done. No one have any doubt, so let's continue with the next one. The next one. So here you can see the baby will have thin infant was delivered. This is the 43rd week. So again, this is the post-term baby. This is the post-term baby. The post-term baby is there. His apneic limb pales and covered with the pea soup amniotic fluid. The pea soup amniotic fluid is there. So pea soup amniotic fluid, remember this is the pea soup. So this is what? Meconium. This is the meconium. The first step in the resuscitations of this infant at delivery should be, see, first you will do the ABC. What is the ABC? That is, first you try to maintain the airways, then breathing, and then circulations. So that you need to maintain. So here what you need to do, suction of the trachea under the direct visions, because this is the baby, and that's why we need to check about the like any other complications might not be possible in that condition. So we will suction of the trachea, and after we will do the multiple suctions. First we will do the suction under the direct visions, and once all the setup has been accomplished, so after that what we will do, we will do the multiple suctions, so that all the materials or all the meconium we can aspirate. So the artificial ventilations with the bag and mask, of course, no, we don't need to give any oxygens. We need to give aspirate those meconium that is going inside the trachea. The administration of 100% oxygen, the catheterization of umbilical veil, artificial ventilation with the endotracheal loop. I hope you understand that this is the note the technique for the resuscitation in this baby. Okay, first we need to clean the airway, then we can go for the oxygens. If our airway is not clean, then what the meaning of oxygens is given? There is no need for that things as well. See, after that a newborn baby has a mild cyanosis, diaphoresis, poor peripheral, there is a poor peripheral pule, hepatomegaly or cardiomegaly. Respiratory rate is 60 breath per minute. So means the respiratory distress is there. Heart rate is 230 per minute. The child most likely has the congestive. Of course, sorry, this is the common. This is the normal. The child most likely have the congestive heart failure. This is caused by. See, all these things about the praxis, about the atrial tachycardia, atrial flutters, atrial fibrillations, ventricular flutter, we will discuss in the cardiology part. Here I am telling you this question. See, if you are getting anything, see, whenever you are getting the paroxysmal means suddenly is there. Paroxysmal means suddenly, or the sudden thing will be there. So suddenly, if then suddenly is there, that is the paroxysmal. That is the proximal. See, sudden increase heart rate at atrial level. See, here is what the atria is there. So the atrial levels, so at atrial level, so suddenly there is an increase at heart rate at the atrial level, and the heart rate for this condition is 150 to 250 per minute. 150 to 250 per minute. Okay, the paroxysmal, what we call suddenly. Arterial, matlab there is a absence of the P wave, that will study, and heart rate we will see in this condition, that will be 150 to 250 per minute. See, if there is a atrial problem in the atrium, so what we will see in this conditions, there will be the P wave will be absent. I hope every one of you know that in the ECG we have the P, Q, R, S, T waves, and in the ECG we have the P wave that tells us about the atrial depolarizations. P waves tell us about the atrial depolarizations. So there will be the absence of atrial depolarizations. That's why the P wave will be absent in case of paroxysmal atrial tachycardia, and due to which the patient will having the mild cyanosis, diaphoresis. So all these things will be possible. And so remember, if you are getting a heart rate, so in this question, in this type of the questions, first check about the heart rate, that if it is the tachycardia, of course that is the tachycardia, but is the 230 beats, so means he is talking about the PAT, that is the paroxysmal atrial tachycardia, and the normal heart rate in this range is 150 to 250 per minute. I hope this is clear. Okay. Now let's continue with the all these things. Again we will discuss like a paroxysmal, because this is a not just a single topic. This topic that you should like understands with the whole things together, like whether it is paroxysmal atrial tachycardia, paroxysmal ventricular tachycardia, there will be the VT, there will be the AT will be there, AF will be there. AF means ventricular fibrillation. So all these things we will discuss mainly maybe on the ECG and the cardio and the cardiology part, because there is a direct questions that you will see in your exam. So that we will discuss in the very concise manner. So you just need to hear, remember that is the paroxysmal atrial tachycardia. If the 230 or the 150 to 250 beats per minute, means that he is talking about the paroxysmal atrial tachycardia. Okay. Next question. A 6-year-old boy was brought to the emergency room with the 3-hour history of there is a 3-hour history of fever up to 39.5 degrees Celsius, and there is a sore throat. The child looks alert, anxious, and has a mild inspiratory stridor. You should immediately see, whenever you talk about the stridor, there are many questions that in many questions you will get this terminology as the stridor. So first let's discuss what is the stridor. Let me write it here. See, the stridor, when we talk, see stridor, it is the like any, we can say the noisy breathing, any noisy breathing, that is the stridor. Any noisy breathing is there, noisy breathing. So any noisy breathing, that is mainly due to airway obstructions, due to airway obstructions. So that is what, that is noisy breathing, that is the noisy breathing. See, in case of the stridor, remember, in case of the stridor, you need to remember that there is a inspiratory stridor. There will be the inspiratory stridor, there can be the biphasic stridor, or there can be the expiratory stridor. So this type of the stridor or the noisy breathing that you seen in these conditions, see, if any inspiratory stridor is there, so if any inspiratory stridor, you need to having that maybe this is the problem or the obstruction. See, first you need to understand that this is the noisy breathing, and this noisy breathing, it is due to airway obstruction. If any airway obstruction is there, it means he is talking about there is some sound is per like this type of the sound you will get. So that is what, that is the noisy breathing or the stridor sounds. So in case of inspiratory stridor, we are having the glottis. Okay, before coming to that, let's discuss about we having the glottis. What is the glottis? See, glottis is what, that is our true vocal cord. The glottis is the true vocal cord. If somebody is saying to you, speak out, or if I say you in the class, speak out, So you are speaking out from where? You are speaking from your glottis, or you are speaking from your true vocal cords. You are speaking from your true vocal cords. When there will be the like abduction of the vocal cords and there is a adduction of the vocal cords, so there are the two things, and due to which you are speaking. So the vocal cords, thanks to your vocal cord that you are speaking, a big thanks to your vocal cord that you are speaking. So so if you are seeing there is a true vocal cord, we call this condition as the glottis. What is subglottis? What is subglottis? See, if you're talking about the subglottis, so remember there is an empty space in the cricoid rings. Subglottis, what you will see, there is an empty space in the cricoid rings, that will be the subglottis. Okay, so the glottis, remember, that is the true vocal cord, and the subglottis, what does that mean? That is empty space in the cricoid rings. That you just need to remember these two terminology. There is a glottis, there is one more thing, that is the supraglottis, that is present like the in the pharyngeal regions, or the regions or the space above the vocal cord. There is one more thing, that is the supraglottis. So if supraglottis is there, that is above the vocal cord, glottis, that is the true vocal cord, subglottis, that is the empty space in the cricoid rings present below the glottis. So if you are getting the inspiratory sound, inspiratory stridor, that will be due to pharynx, and supraglottis and supraglottic. In case of the biphagic, see, agar biphagic, if you are getting the biphagic, so remember we are getting the glottis, subglottis and cervical trachea के केस में. So biphagic stridor, if any problem in the glottis, any obstruction in the glottis, any obstruction in the subglottis, any obstruction in the cervical trachea region, so that they produce the biphagic stridor. If any obstruction in the supraglottis, the region above the cervical trachea, that produce the inspiratory sound, the sound during our inspiration. In the expiratory sound, remember we will be having the thoracic trachea, and we will be having the that is bronchi. If any problem in the bronchi regions, any problem in the thoracic trachea, that produce the expiratory sound. Okay, I hope this is clear. So based on that, let's discuss. I hope this is clear that stridor, we have the abnormal noisy breathings, or we can say the inspiratory or the expiratory low pitch voice. Okay, so let's discuss some related disorder with that. See, what is the most common cause of stridor? The most common cause of stridor. The most common cause of stridor, remember, that is what? That is laryngomalacia. The most common cause of stridor, that is the laryngomalacia. The laryngomalacia, that is the most common cause of the stridor. Then remember that if in case of when we talk about the, let's discuss further about the laryngomalacia in details. See, when you are talking about the laryngomalacia, remember, when we are it will increase on the supine. Okay, let me write. Okay, this is the heading. So we have the laryngomalacia. See, in case of the laryngomalacia, what we are studying. I think my voice is clear. Sorry, I think just a second. Okay, see, laryngomalacia. Now, okay, everything clear. Laryngomalacia, that is what the laryngomalacia, remember, that is like this is the most common cause of the stridor. And what type of the stridor we seen in these conditions? See, the laryngomalacia, when we are talking about the stridor, we will see that the distress will be increased on supine positions. The distress will be increase on supine positions, the increase on the supine positions, and the relieves on the prone position. The relieves on the prone positions. Okay, along with that, remember, this is the most common congenital anomaly, the most common congenital anomaly of larynx, the most common congenital anomaly of the larynx. Along with that, we already studied, this is the most common cause of the neonatal stridor. There will be the problem with the weakness of supraglottis. So tell me if any supraglottic problem. So which stridor will be there? Yes, you are all right. There will be the inspiratory stridor. There will be the inspiratory stridor will be there. The inspiratory stridor will be seen in these patients. And also remember, this stridor, they will increase on crying. Their stridors will increase on crying and sucking of milk. So when the baby is here, we also remember this point, the distress they increase on the supine positions and the relieves on the prone positions. And also remember one more point here, that if the baby is crying and baby is sucking the milk from the breast, so that at that time the baby mouth is open, and due to which there is stridor will be increased, due to which at that time the stridor will be increased, and the stridor, remember, that is the decrease or the relief in the prone position. So what you need to do the patients, do the baby on the prone position. Prone position, I hope every one of you know. Then prone position, when you are doing the push up, when you are doing the push up, so at that time you will be having the prone position. Supine position, super, the superior, on the upper side. If everything is on the upper side, your hand and everything is on upper side, that is the supine positions. So this is clear. What is the treatment that you will see? This is the laryngomalacia. On the x-ray, if you see, or the laryngoscopy, you will see. On the laryngoscopy, what you will see there will be the omega shaped sign, omega shaped epiglottis. The omega shaped sign, or we can say this is the omega shaped epiglottis, will be seen in these conditions. And what is the treatment that we will give here in these conditions? See, in most of the pediatric patients that we give, that is the reassurance. What we give? The reassurance to the mother. Laryngomalacia, we are having the stridor, the distress, increase on the spine, most common congenital anomaly of the larynx. There is a weakness of the supraglottic part. There is a, due to which in the supraglottis, which stridor we will see, there is a inspiratory stridor. The problem during the inspiration, or the noisy breathing during the inspiration. The stridor, the increase on crying and sucking of the milk. What is the treatment we see? That is the reassurance. The treatment we see, that is the reassurance. I hope this is clear and this is done. Okay, if let me take this opportunity to discuss with you that is which is the most common cause of common cold. The most common cause of common cold. I hope every one of you know. Yes, you all are correct. That is the rhinovirus. That is rhinovirus. Okay, tell me which is the most common cause of pharyngitis. Which is the most common cause of pharyngitis? So what is that? That is, yes, again you all are correct. That is adenovirus. Which is the most common cause of croup? The most common cause of the croup. This croup, that is acute laryngotracheobronchitis. We will just study after this. So that is the parainfluenza virus. The parainfluenza virus. Oh, nice. Many of you already wrote it. So that is a parainfluenza virus. Okay, tell me most common cause of whooping cough. Whooping cough also we will discuss. Whooping cough. What is the most common cause of whooping cough? Yes, everyone is calling BP. What is the BP full form? Bordetella pertussis. Bordetella pertussis. You all are very, very intelligent guys. Then tell me, okay, last one, the most common cause of bronchiolitis. This we already studied, so let me know. Bronchiolitis. Yes, again you all are right. Yes, yes. Okay, okay. So that is, we are very good. The RSV. What is the RSV? Respiratory syncytial virus. Respiratory syncytial virus. Okay, okay, okay. Okay, what is the the common cause of the acute epiglottitis? Streptococcus pneumonia, Haemophilus influenza B. Okay, so see, they have some confusion here in the case of acute epiglottitis. Previously, it was about that there is the someone was saying that acute epiglottitis. Previously, it was considered that the Streptococcus pneumonia is the most common cause of acute epiglottitis, but currently we are getting the Haemophilus influenza B. But we know we are studying for the croak 2. So for croak 2, what you need to remember, we are on the old concept still now. We Ukrainian ministry is still on the old concepts now. So that's why you need to remember that there will be the both options can be possible in your exam. Swaha. Okay. So let's discuss about the acute epiglottitis. The acute epiglottitis. See, acute epiglottitis. So remember that in case of when we talk about the acute epiglottitis, what is the cause of the acute epiglottitis? So remember that is Haemophilus influenza B. Haemophilus influenza virus. Which one? Which serotype is the B? Haemophilus influenza virus. And if this is not in the questions, then you can choose the Streptococcus pneumonia. If this in the questions, then you need to choose Haemophilus influenza B. Again, if this questions is in the ministry, you will get, just send me the questions, so we will discuss according to that what can be the answer. Okay, what the sign we will see in case of acute epiglottitis? Yes, thumb sign. Like in acute epiglottitis, what is the thumb sign we will be seeing? See, this case of acute epiglottitis, this is the case in case of acute epiglottitis, remember, it is the bacterial infection. It is the bacterial infection of, supraglottis. It is the bacterial infection of the supraglottis. So again, I hope every one of you know already what is that in case of acute epiglottitis. Bacterial infection of the supraglottis. So which stridor will be there? That will be the inspiratory stridor. Inspiratory stridor will be there. Okay. Then after that, in case of acute epiglottitis, remember this is common in between the age having 2 to 7 years. The 2 to 7 years. Okay. What are the clinical presentations or the features we will? Clinical features. See, in case of the clinical features, when we talk about the clinical features or the clinical presentations, so always remember these patients will be having the respiratory difficulty. The respiratory difficulty will be there, and that is the severe respiratory difficulty. Along with that, these patients will be having, as we already discussed, this patient will be having the inspiratory stridor. Is this patient having the fever? Yes, sir. They having the high fever. What high fever? Till which degree? 103 to 140 degrees Celsius minimum. Is this patient having, sir, drooling of saliva as well? Yes, this having the drooling of the saliva. Does this patient having the potato voice? Yes, they having the hot potato voice will be there. So that is what hot potato voice means. Someone's putting the potato inside and try it at your homes. Okay, don't try this at home. So that we also call the plummy voice. The child's if you are getting the images you will not get, but image descriptions you can get. See, most of the times you don't get the images, but if they will give you images also, you don't need to worry, that become the questions will become easy. So if the child sits bending forward, the child sits bending forward, we call this condition as the tripod positions. We call this condition as the tripod position. Okay, or tripod positions or the tripod signs. The baby will be have on the tripod positions and the tripod sign will be there. The sign we studied, that is the thumb sign. Why the thumb sign? Because of the swollen epiglottis. Because of the swollen epiglottis. I hope this is clear and this is done. Cause H influenza B, thumb sign, bacterial infection of the supraglottis, respiratory difficulty, inspiratory stridor, high fever, drooling of saliva, hot potato voice, child sit bending forward, tripod position, sign. Okay, okay. Thank you. You're welcome. Bye. Good night. सो जाओ. Then let's discuss about the treatment. देखो ट्रीटमेंट में सबसे सेम चीज वी नीड टू डू द एयरवे मैनेजमेंट, बिकॉज जितना भी एयरवे ऑब्स्ट्रक्शन डिजीज है, द फर्स्ट ट्रीटमेंट विल बी द एयरवे मैनेजमेंट. तो एयरवे मैनेजमेंट बाय लाइक वी डू द इंटूबेशंस, है ना, we will do the intubation. So first the treatment you need to do the airway management. After that you can go for the steroids or antibiotics. Steroids or antibiotics. Okay. The next one we having, that is the I think croup. Yeah. The next one is what? Croup. The next one is the patient will having the croup. Can you tell me the another name of the for the croup? The croup, remember, this is also known as the laryngo tracheo. This is also known as the laryngo, or we can call the mainly the croup we call the acute. So acute conditions. So remember, this is called it acute condition. Acute laryngo tracheo bronchitis. Acute laryngo. So this is the acute laryngo tracheo bronchitis. In the questions you can get laryngotracheobronchitis. In the questions you get only tracheobronchitis. In the questions you get laryngobronchitis. So all these things mean same. The full name is acute. This is acute laryngotracheobronchitis. That is croup. What is the croup? See, okay, it is the viral infection. Is it viral infection? Oh yes. Oh yeah, that is viral infection of complete airway. The viral infection of the complete airway. But there is a, see, read it carefully. It is the viral infection of the complete airway. But they can, in the questions they can give you like one thing, which part is affected the most. So remember the but subglottis is affected more. The subglottis is affected more than croup. Okay. Then which, okay, viral infection. Which viral infection? So that is, which viral infection? Yes, you all are right. That is para-influenza virus. Para-influenza virus. And see, we studied in the acute epiglottitis, that is common in the age 2 to 7 years. But when we talk about the croup, so remember this, the age for this croup is what? That is how many? Yeah, 3 to 3. 3 to 3. So 3 months to 3 years children. 3 months to 3 year children, we call this condition as the croup. This is also known as the acute laryngotracheobronchitis. Is it viral infections? Yes sir. Is it viral infection? Is the viral infection of complete airway? Yes, it is viral infection of the complete airway. But subglottis is affected more. Yes sir, subglottis is affected more in this condition. Is it viral that you are talking is parainfluenza virus? Yes, that is parainfluenza virus. You all are right. Wow, so much grateful, so much good to listen. Then clinical presentations, what we will study. Sir, is it respiratory problem will be here? There is a airway obstructions. कैसी बात कर दी है ना, छोटी बात कर दी तो बिल्कुल very little talk you did. Respiratory, I know that. So there is a respiratory difficulty. See, the respiratory difficulty, that will be the mild. Is the biphasic stridor? Sir, you are saying that there is a viral infection of the complete airway. है ना, viral infection of the complete airway. Then come on, in subglottis also you are saying that affected more. So subglottis, we already know there is a biphasic stridor. Don't make us fool. We all not are fool. We are the like the sincere guy, and we all are the intelligent. So which glottis in the subglottis? Of course, you just tell us that is the biphasic stridor now. So why you are asking us again and again and disturbing us? है ना, यही सोच रहे हो ना? That is what again we are seeing here, the low fever. In acute epiglottitis there was the high fever 1032 104 degree. Are there barking cough? Barking, भोगने वाली cough, भोंकने वाली. And this barking cough is due to broncho. This is due to bronchospasm. This is due to bronchospasm. Okay, which sign is there in the epi view? X-ray sign. Sir, X-ray sign तो हमें पता है, आप बता दो. But हमें पता है, we already know. But हम आपके मुंह से सुनना चाहते हैं. यही मेरे को I know कि तुम्हें पता है. Just you wanted to know from my mouth. है ना? So that okay, I'm telling you that is what, that is the steeple signs. Every one of you know already. So that will be the steeple sign. Church, you know the church. I don't know how to make the church. In the church you will say this type of the things. So this is what the steeple. This is what the steeple signs. This is what the steeple signs. So the trachea will be looks like this. This will be the steeple sign. This will be the steeple sign. Why? Why the steeple sign, sir? Due to narrowing of which part? Subglottis. The narrowing of the subglottis, or they can get, if they are the good examiner, they will give directly to the steeple side. If they want to check your informations or the knowledge, they will give you narrowing of the subglottis. But that is not. They can ask you anything. You are ready to answer anything. So the treatment here is what? Humidified oxygen. Statement is what? Humidified oxygen, humidified oxygen, humidified oxygen. Twin, 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 twin. Is there bronchospasm? So can I give the bronchodilator? Yes, sir. Can we give the steroids as well? Yes, sir. Can we give the antibiotic as well? Yes, sir. There can be the other. But sir, you told viral infection. Why you are giving the antibiotic? Are you mad or what? I don't understand. So that's in, remember, antibiotics to prevent the secondary infections. Antibiotics to prevent any secondary infections if there. This is not mandatory. And that will not ask me in your questions. In the question they can ask you about that there can be the humidified oxygen is possible, bronchodilator can be given, steroids. So these questions can be asked. This will not be asked. Then you are seeing there is a respiratory difficulty, biphasic stridor, low fever, barking cough. Can you tell me about the barking cough? If you are telling whooping cough, the whooping cough. Okay. I hope this is clear till now. So let's discuss about one more thing, that is our whooping cough. See, whooping cough when we talk, that is caused by the Bordetella pertussis. Yes, abhi to just you told us, then you again are telling us the whooping cough that is caused by the Bordetella pertussis. Bordetella pertussis. Bordetella pertussis. Bordetella pertussis. What will be seen in case of whooping cough? The hallmark features. The hallmark features, we see that there is a apnea will be there. There will be the bradycardia. Bradycardia. There will be the cyanosis will be there. Sir, so it means can you give the azithromycin? Azithromycin can be given. Can you tell me what the azithromycin class? So that is macrolides. Okay, that is the macrolides. So we having the whooping cough, Bordetella caused by the Bordetella pertussis, hallmark, apnea, bradycardia, cyanosis will be there. So that you need to remember, and that is done about the whooping cough. And we studied about the acute laryngotracheobronchitis. That is the most important questions that will be repeated again and again. Acute epiglottitis, again they are very important questions. Along with that, we studied that there is a acute epiglottitis, we studied there is a croup, we studied that there is a whooping cough. Bronchiolitis we studied, I think, in the previous classes. If not, then I'm repeating it again. See, bronchiolitis, the bronchiolitis, remember what is the cause of bronchiolitis? That is RSV, respiratory syncytial virus, respiratory syncytial virus. Okay sir, yes sir. So what the in the whooping cough, sir? Whooping cough na, that is means we that bronchiolitis is there, so there is inflammation of the bronchioles, there will be the inflammation of bronchioles. Okay, then you need to remember these things only for this. And the treatment, sir, what the treatment, can you tell me? Sir, treatment, again there is a problem with the bronchiolitis, so we can give humidified oxygen. Humidified oxygen is given. Okay sir, thank you so much sir. So okay sir, that is what, sir, other conditions can be seen in this bronchiolitis. Yes, there will be the hyperinflated chest. But remember that for the croak point of view, if you know the bronchiolitis is caused by the respiratory syncytial virus, that is more than enough. That is more than enough. Okay, so I hope this is done. So if any stridor problem, means there is a problem with the obstruction, airway obstruction is there. So airway obstruction is there, what we need to do? Sir, we need to prepare to stabilize an airway. Okay, my dear friends. Okay, I understand that you are all are good. Okay, so now let's do the next questions. A 7-day-old boy is admitted to the hospital for evaluation of vomiting. Here is what? 7-day-old boy. Is it congenital? Yes. Is vomiting and dehydration. Physical examination otherwise normal except for the minimal hyperpigmentation. Physical examination otherwise normal. Okay. There is a minimal hyperpigmentation of the nipple. If it is given in the questions, it can be the things. Serum sodium or potassium concentration be given hai. So the most likely diagnosis is here serum sodium and potassium. When comes in the question, I always think about the aldosterone, because aldosterone, I know one thing about the aldosterone, that it is the hormone. It is, we in the adrenal cortex we have the GFR, glomerulosa fasciculata reticularis, zona glomerulosa, zona fasciculata, zona reticularis. Then we have the mar gaya sala, that is MGS, mar gaya sala, MGS. So zona glomerulosa, they secrete the mineralocorticoid. Mineralocorticoid is aldosterone. Mineralocorticoids is aldosterone. Then fasciculata is what? That is the glucocorticoids. Then reticularis, zona reticularis, that is the sex corticoids. So mineralocorticoids, glucocorticoids, this is the zona glomerulosa, this is glucocorticoid hormone. So zona glomerulosa, zona fasciculata, zona reticularis, these are the layer that is seen in case of adrenal cortex. Zona glomerulosa, they secrete mineralocorticoid. Fasciculata, they produce the release, they form the glucocorticoids. Reticularis, they form the sex corticoids. Okay. So aldosterone, I know one thing about the aldosterone. Sodium gaya, welcome sodium, bye bye potassium. 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 So welcome sodium, bye bye potassium matlab sodium in, potassium out. Sodium in, potassium out. Sodium in, potassium out. Sodium will be in, potassium will be out. Sodium will be in, potassium will be out. that is welcome sodium, bye bye potassium. Okay, so aldosterone will be there, sodium in, potassium out. So it means if the sodium is in, so what is the normal level of the sodium? What is the normal level of sodium? So normal level of sodium, sir, I hope every one of you know already these things, 135 to 145 milli equivalent per liter. Okay, okay, sir, tell me about potassium. Potassium is 3.3 to 5.5 milli equivalent per liter. Sir, here is 120, means sodium is less, and here is potassium, so potassium is more, means electrolyte abnormality है sir. एल्डोस्टेरोन, सर एल्डोस्टेरोन ज्यादा है या कम है पता नहीं चल रहा, तो एल्डोस्टेरोन कम है सर. अगर एल्डोस्टेरोन कम हुआ तो सोडियम कम हो जाएगा, पोटेशियम ज्यादा बाहर जाएगा. पोटेशियम क्या हो जाएगा? पोटेशियम कम बाहर जाएगा, पोटेशियम कम बाहर जाएगा, सॉरी पोटेशियम, सोडियम कम हो जाएगा, पोटेशियम कम बाहर जाएगा, तो पोटेशियम हमारी बॉडी के अंदर ज्यादा होगा. तो पोटेशियम ज्यादा, सोडियम कम, एल्डोस्टेरोन डेफिशिएंसी इज देयर. बट हेयर यू आर सेइंग एड्रिनल हाइपरप्लेशिया. अगर एड्रिनल हाइपरप्लेशिया है मींस देयर इज इंक्रीज इन द यस नंबर, तो इंक्रीज इन द नंबर ऑफ द हार्मोन्स और द हार्मोन सिक्रेशन ज्यादा हो रही है, देन कैसे एल्डोस्टेरोन कम हो सकता है? चलो देखते हैं, लेट्स कम. Congenital adrenal, so this is we did the 50, yes, congenital adrenal hyperplasia, congenital adrenal hyperplasia. See, congenital adrenal hyperplasia, the congenital adrenal hyperplasia, remember this is autosomal recessive condition, this is autosomal recessive conditions. Okay, and this is due to deficiency of enzyme in adrenal, deficiency of enzyme in the in adrenal biosynthesis. So this is the which is definitely most common enzyme, most common is what, that is the 20. देखो there is a many enzyme that deficient, 21 hydroxylase, 17 hydroxylase, 21 hydroxylase, 121 dihydroxylase. So all these can be the possible, but the most common you need to remember that 21 hydroxylase deficiency will be there. So if this enzyme will be deficient, there will be the decreased synthesis, because this hormone help in the adrenal hormone synthesis. If this hormone is decreased, so there is a decreased synthesis, there is a decrease the synthesis of adrenal hormones, they decrease synthesis of the adrenal hormone. And which hormone? Especially glucocorticoids. Especially which hormone? Glucocorticoids. Especially the glucocorticoids will be there. If there is a decrease in the adrenal hormone, we know that this adrenal gland, they are this adrenal, we have the adrenal gland, we having the adrenal gland, okay, and we having the pituitary gland. The pituitary gland, everyone knows that it releases the ACTH, they have the effect, or they have the effect on the adrenal gland. If this, and that's based on that we describe the Cushing disease and Cushing syndrome. This one you should know. If you don't know, you can ask me in the WhatsApp group or anywhere. And a pituitary gland, ACTH, stimulate the adrenal gland. So adrenal gland, they release the, they act on the adrenal gland, which part? Cortex, the cortex part, and they having the layer GFR, and GFR will release the mar gaya sala. So here we are seeing there is a more effect on the glucocorticoids. The glucocorticoids level will decrease, and this glucocorticoid level further what they will do, they will stimulate the, or they will give the negative feedback to the pituitary glands. And when the pituitary gland will be there, the decreased synthesis of the adrenal hormone, and due to feedback control, there will be the increase in ACTH, adrenocorticotropic hormone, ACTH hormone. And when the ACTH hormone will be increased, there will be the stimulation, of adrenal gland, there will be the stimulation of the adrenal gland. And when the stimulation of the adrenal gland, there will be the hyperplasia of adrenal gland. there will be the hyperplasia of the adrenal gland. So if there is a hyperplasia of adrenal gland, so this conditions will be seen. This condition will be seen when there is a 21 hydroxylase deficiency. Then I told you that if this 21 hydroxylase deficiency, glucocorticoids will be decreased. There is a one more enzyme, that is 17 hydroxyl. There is one this enzyme only, not 17. This is 21 hydroxylase deficiency. They will also decrease what? Aldosterone. What they will decrease? They will also decrease the aldosterone. So if aldosterone will be decreased, there will be a decrease in the sodium level and increase in the potassiums respectively. Okay. If there is sodium level is decreasing, so it also having the effect on the blood pressure. So BP will also decrease. The blood pressures will be also low, and the patients can go into the hypotension, and further it can lead to the hypotensive shock. I hope you are connecting each dot. If there is a decrease in the aldosterone, what they will do? They will increase the ACTH again, or again the glucocorticoids will also. This ACTH, they have the similar effect like MCH on skin. What is the melanocyte stimulating hormone? This is the melanocyte stimulating hormone. So this increased ACTH, what they have the effect like the same effect of the MSH. So what they will do? They cause the hyperpigmentations. They cause the hyperpigmentation. Okay, so this is what we have, the congenital adrenal hyperplasia, that you should know. This is the like very concisely I remember. There is many things much more in this condition. There is 17 hydroxylase and 21 121 dihydroxylase deficiency. So the treatment you need to remember what we will give, the lifelong. There is a lifelong hydrocortisone plus along with that we do the fludrocortisones. Fludrocortisones. So this you need to give. Okay, I hope this is clear and done. See, the congenital adrenal hyperplasia, there is a deficiency of enzyme, most common 21 hydroxylase, then decreased synthesis of adrenal hormone, especially the glucocorticoid, the feedback, there is increase in the ACTH, stimulation of the adrenal gland, there is a hyperplasia of adrenal gland, due to which, if there is hyperplasia of adrenal gland, we call this condition as the, because this present is due to deficiency of enzymes and that present from birth, deficiency from the birth. That's why we call this condition as the congenital adrenal hyperplasia. If the congenital adrenal hyperplasia is there, so there is a hyperplasia of the adrenal gland will be there, and this hormone, this 21 hydroxylase deficiency, this can also lead to the decrease in the aldosterone as well, and due to which there will be the decreased sodium, sodium will be decreased, potassium will be increased. That's what we are seeing in the questions. So we can see that there is a decrease in the sodium and increase in the potassium. So there is an increase in the ACTH. The similar that have the ACTH have the similar effect like MSH, melanocyte stimulating hormone. We know melanocyte, they will do. They stimulate the melanin hormone. They act on the melanocytes, and what they will do? They have the pigment. So this is the skin pigment we have, that is melanins. So if this pigment they having the, so that MSH have the similar effect on the ACTH as well. So what they will cause? ACTH will cause the hyperpigmentations. The treatment we will do, that is the hydrocortisones. The treatment what we will do, hydrocortisone or the fludrocortisone. So I hope this is clear till now, and this is what the questions here we can see here. In this question, the physical examination is normal. There is a vomiting, dehydration, 7-day-old baby. Minimal hyperpigmentation of the nipples, that is due to hyperpigmentation. Sodium and potassium is level low. So baby, you can see the age, you can see the hyperpigmentation feature. You can see there is a concentration of sodium and the potassium, that is due to congenital adrenal hyperplasia. Pyloric stenosis we will discuss in the next class. Panhypopituitarism, when all the hormones of the pituitary gland they decreased. So that is not possible in this condition, because in this condition they didn't give any other history other than adrenal things. Then the hyperaldosteronism, no, there will the not hyperaldosteronism. We know that this condition is due to decrease in the aldosterone. That's why the sodium is decreasing. Secondary hypothyroidism, it will be possible if they will give you something history about the thyroid, weight loss, anything is there, or maybe they will give you something about the thyroid stimulating hormones. They will give you something about the problems having the, if hypothyroidism is there, any other disease associated should be there, like, or maybe any due to that disease there decrease in the thyroid hormone will be there. That's why we called it secondary. So that is again note your option. Okay, so we finished the question 50. So we make the half century. Okay, so let's make the 51. So there is a crampy abdominal pain that you need to do it by yourselves. Crampy abdominal pain, there is a rash on the back of the legs, the buttock is there, laboratory NSA reveals proteinuria, microhematuria. So what is this conditions? Write me. What is that? That is hinox colon purpura. What the another name of that? You need to write me. And this condition is also known as the anaphylactic purpura. Okay, the other questions we will discuss in next class. Okay, so I hope this is clear till here. So please keep revising everything and again, and don't worry about anything else. Just whatever you are getting, just keep revising all those notes again and again, and don't waste your time, or don't waste just a single minute in anything. Just be focused and patience, be patient, revision and consistency is equals to success. So make sure that you are on perfect on all these things. You should be having patience, you should keep doing the revisions and be consistent till whatever you don't achieve your goal. So the goal should be your first priority. Other things are unnecessary. Only your goal is necessary at this point. And just you have the 2 months. So just please, my advice, just keep revising. Just be focused. Just think about your parents. They are working very hard. So don't waste a single minute, or don't do unnecessary things commonly. Okay, so see you in the next class. Goodbye, good night, see you later, bye bye.